Thank you very much. I was asked to give you a sort of tour d'horizon of the future challenges in a holistic way, of benefit-risk assessment. Now, I decided that I want to base this on an analogy that is close to your heart, because this is how your nervous system functions, your and mine. Imagine you inadvertently put your hand on a hot surface, like an oven. What will happen is that a signal travels inwards to your central nervous system. In this case, this is a cross-section of your spinal cord. That signal is then processed, and then another signal travels outward that leads to a reaction. Ideally, you remove your hand from that oven as fast as you can. And I think what we do here is pretty close. There's incoming stuff, we process it, and then it goes out and leads to some reactions in the outside world. Now, that slide, to be clear, is not to say that regulators customarily think with their spinal cord. We also have a brain, but this is easier to conceptualize. So, let me structure it in that way. Let's first talk about what comes in. And here we have to talk about noise, signals, data, and information. That's not the same. If we had sat here 10, 15 years ago, and you asked us what comes in, what is the stuff that you base your decisions on, you would probably have gotten something like that short list. It used to be largely randomized controlled trials, sometimes uncontrolled clinical trials, and then a lot of these spontaneous reportings that physicians are meant to do, or were meant to do, about adverse events when they observe something. And that was, I do oversimplify, but pretty much that was the list several years ago. Now, the world around us is changing. And in this brave new world, we have a lot more input now in terms of data or information. We have registries, observational studies, other types of trials, and then come new types of data that are totally unheard of or were unheard of a couple of years ago. Many of you will know what Patients Like Me is, a network of patients, and they pride themselves that they have over 1 million treatment and disease experiences on their website, in their archives. This is a potentially useful source of data. We know that there is now digital social media apps where you can register, a lot of health apps, where you can register disease experiences, treatment experiences, etc. How do we make use of that? And then there is anecdotes and media reports. So all of that goes in. And it is like a cacophony of incoming signals, not all of which are very useful. Let's talk about noise. If you ask me what was the most useless and at the same time most popular in terms of media coverage safety event over the past years, it was probably this, about a drug in Europe called Champix, in the US is Chantix. There was this wannabe rock star in Texas who exhibited some strange behavior, and he came to a bizarre death. As you can read here, his girlfriend raised the story, it wasn't him, it was the drug. That went viral. We were faced with journalists who say, how many more people have to die before you remove that drug from the market? The sponsor of that drug, Pfizer in that case, had to do a large study. What came out was essentially nothing. It died down, but it was a signal that we had to deal with. The drug is, of course, still on the market now. Nobody talks about it. We have a lot of such false signals. A colleague of mine, and maybe this is underappreciated by the outside world, a colleague of mine analyzed that. And he found that in the past 4 years, this is a year ago, EMA reviewed over 7,000 potential drug safety problems. And only a very, very small minority, 1 in 157, this is huge, only a very small, gave rise to action. Now, you could say maybe we overlooked some. Possible, but the fact is that a lot of what we receive here as incoming messages is false. And the difficulty for us is to differentiate what is a signal, what is noise, even before you go into benefit risk. And the question is for us, what should go into that? not a trivial question. And this is a question that in future, as we get more and different types of signals, will become aggravated and will become more complex for us. So how can we deal with that? If you happen to be medically qualified as I am, and you grew up at around the time when I was educated, you will recognize that so-called hierarchy of evidence. That was the high point, or is the high point of evidence-based medicine. And there is still a school of thought who says, look, if some information is not from a randomized controlled trial, ignore it. Life is too short to read that kind of stuff. We hear that from the Cochrane collaboration, from others. So we're using that. The regulatory world is very strong on that. We use this. Interestingly, the regulatory world also uses the bottom part of this. Case series is what we have been using for decades. This is the adverse event reports that come in. In Europe, we call them vigilance. We have a database for that. We analyze that on an ongoing basis. And we use a lot of expert committees. This is what some people call eminence-based medicine, very derogatory, but we have to use it. So this is where traditionally we have been strong. Where we are or have been weak is that middle ground here, the orange part. We have not a lot of experience with that type of studies, and yet more and more of that stuff is coming in. 2 days ago, there was a report in the Journal of the American Medical Association out of Denmark saying if you're pregnant, you take paracetamol, your child has a higher risk of some behavioral disorders. True, false, I don't know. But this is the type of information that is now coming in and that we have to come to grips with. That is what I would say one of the key challenges in the incoming stream of that benefit-risk assessment that we have to tackle. We're trying to do that. We're leading a major long-term project called PROTECT, where one of the deliverables is to explore methods to address the data heterogeneity. So how can you reconcile different outcomes from a randomized controlled trial with that from an observational study, with signals that you receive from physician reporting, from patient reporting, etc. So I will not go into the details here, just to give you a glimpse of the frontiers of benefit-risk assessment on the incoming side. Now, let's move on, so to speak, and go right into the central nervous system, the information processing. So here we have to talk about facts, values, uncertainty, risk aversion, and all that. Let me start with a simple question. What do you expect from your friendly regulator in Europe? If you want to close your eyes and think of that response. Before I came here, I probably would have said something like, well, you guys should take the right decisions. That is what you're paid to do. Very good. But what is the right decision? It's like beauty, which is in the eye of the beholder. I found a very interesting paper that was published a couple of years ago, and it was not so much about the regulatory decision, but about the decision of health technology assessment bodies. And these people said rightly, decisions in healthcare are rife with moral disagreements. And we have heard exactly that this morning. And we know it from experience. If a drug is authorized or kept on the market, there is invariably an aggrieved group that says, often academics or consumer protection organizations, who say, how can you authorize this drug? Did you not notice the adverse events? This is irresponsible. If we do not authorize it, we hear from some patient representatives, how could you not make this available to us? This was my last hope, or my child's last hope. So we're caught in between that. And I would argue that unanimity of opinion in this space is a very elusive goal. I often say to myself or colleagues, look, if you want to be universally loved, you better get yourself another job, because this is not the right place to be. So we cannot strive realistically to take the right decision, because there isn't one. But we could strive for something else. And that is very interestingly described in that paper. They call it accountability for reasonableness. And that is something we should achieve. We should be accountable, we should be reasonable. And they identify 3 elements in the decision-making process. The first is transparency. This is an obvious one. So tell me, what were the data, what was the basis on which you took that decision, and tell me how you took the decision and justify it. Fine. That's very clear. And that is, by the way, why we are currently engaged in a prolonged struggle about transparency of clinical trial data. Because this, we see that as part of our job. The next thing they identify here as a criterion for that is relevance. That is not so easy to understand. What they mean is this. What is relevant to one individual or stakeholder group may not be relevant to another. And we've heard it throughout this day today. And if a patient representative comes to us and says, to me it is not relevant whether my son with muscular dystrophy does a good 6-minute walk test. To me it is relevant how fast he gets out of his chair. Fair enough. Then have we taken that into account? That doesn't mean we have to agree with it. And we could tell that patient or that parent, look, we understand, we have considered it, but for the following reasons, we don't think it is a good criterion to base a decision on. Then we may have done a good job. If our response is, what? No, we haven't considered that, we don't know what that is, then maybe we have not done such a good job. That's relevance. And the last one is a no-brainer, revisability. If new information or data come in, you have to revise your decision. So, today you've heard a lot about structured decision frameworks. And Francesco was the last speaker, and Hans Hilliger in the morning told you about all these endeavors that are currently ongoing. Now, the question is, if we did that, whether it's this model, MCDA, or effects table, or something else, would it add transparency and relevance? And that's the question we are currently struggling with. I believe yes, it would, because it would lay open and go from implicit decision-making to more explicit decision-making and say, what are our value judgments? Why did we arrive at that particular decision? I think it would. But there is another question that I believe we have not discussed today, and it's like an elephant in the room. Assume we did all that. Assume we adopted the MCDA model or something else. Assume for every decision we took, we would elicit patient preferences, maybe along the lines of what you tried to do in this little exercise earlier this afternoon, or a different methodology. That's not the point here. Assume we did it. Would it change the outcome of the regulatory decision? Well, to do that, we have to look at what is the decision criterion actually for a regulator. And I would say it is embarrassingly simple. If you want to buy a new car, you have a lot of competing objectives. You have to look at price, speed, comfort, style, model, whatever. For us, in theory, it's much easier. And I want to give credit to Francesco, who brought me onto this. It's really just 2 questions that you have to ask yourself as a regulator. Question 1 is, do the benefits outweigh the risks? And question 2 is the degree of uncertainty around those benefits and risks acceptably low? And only if you can say yes to both of these questions, then you should be positive. If you say no to one of the 2, then you should be negative. That's a very simple decision rule. By the way, I put down this BHU because I really like it. This is what our Canadian colleagues are now using, and they have new legislation in Canada where they say we should not talk about benefits and risks because it's misleading. They only talk about benefits, harms, and uncertainty. So any new therapy does something good, something bad, and there's a lot we don't know about it. Intuitively, I like that actually much better than our benefit-risk model. But that is a personal view. So if we take this into account, we have to invariably talk about attitude or tolerance towards risks and towards uncertainty. Now, how would that change if we did one of those models? And now allow me a very quick digression, and I want to give this a light touch because it's late in the day. There is a book called Thinking Fast and Slow by a chap called Daniel Kahneman. He got a Nobel Prize in economics. If you have not read it, you should. It's really good. What he says is, in theory, a certain commodity, a thing, should have a value for you, one single value. Take 100, he says, dollars, you take euro. 100 euro is 100 euro, right? That's it. And it may be a lot for you if you are poor, or it may mean very little if you're rich. But it should not be contextual. And he says, wrong. It is very contextual. 100 euros is not the same whether you stand to gain 100 or lose 100. And this is what this graph shows. So on the horizontal axis, you have the dollar amount, or euro, 100 or 200. And on the vertical axis, you have a psychological value. And you see that the positive psychological value is not the same as the negative. And he illustrates that by experiments that apparently have been done by some psychologists. This is what social scientists apparently do all day long. So it goes like this. Imagine I offered you a bet. I say imagine. I do not really do it because I would go bankrupt if I did. Let's say I toss a coin up in the air. There are two possible outcomes. Heads come up, then I pay you 150 euros. Or tails come up, then you pay me 100 euros. Would you want that bet? Again, think for yourself. Would you want me to do that? If you were a rational utility maximizer, this is what economic theory says we all are, there is only one logical answer, and the answer is yes. Because you don't have to be a mathematician to understand that the expected utility of that coin toss is positive. So you must say yes. If you do the experiments with young people, with people like us here, the majority would say no thank you, because we are loss averse. And then you can modify the experiment and you change the parameters. And if you do that, you will find out that on average, we flip when the ratio of gains to losses is like 2 to 1. So if I offer you 200 versus you pay me 100, then the majority would say, yes, go toss the coin. This is loss or risk aversion. Now, why am I telling you this? We're not here to talk about money. We're here to talk about health. So let me replace on that graph the horizontal axis by some quantity of health. And there are measures. QALY stands for quality adjusted life year, and LYS stands for life years saved. There are a few of those. But let's make it simpler. Just think of a heart attack. A heart attack is something you don't want to have. In the context of a treatment, that could be a gain or a loss. I'm sure some of you in this room take a statin. If you take a statin, you do it because you want to avoid having a heart attack. So you see this as a gain. There are other drugs where a heart attack is an unwanted side effect. We have been in a big debate about a diabetes drug. Does that increase the probability of having heart attacks? So the question we have to ask ourselves here is, do we treat a heart attack, which is 1 unit, like 100 euro, do we treat it symmetrically when it is a gain or when it is a loss? What do you believe? I don't know. And I don't think anybody has the answer. I asked Andrea and other people who are in Hans, do we know, do we have any data, whether we are symmetric or asymmetric? Are we risk averse? The only thing I found was an interesting study that is several years ago, and that was a survey done amongst physicians at Stanford University Hospital. And these people, these authors, used some simple questionnaires or question technologies that you use in decision sciences. And they said to physicians, look, here is a treatment that could save a life, but it also has some nasty side effects, so it could cost a life. It could cause your patient to die. And then they teased out that symmetry or asymmetry. And what I've written here is just excerpted from that paper. They found that on average, those physicians said 4 or 5 additional lives had to be saved by better treatment of the disease for each additional death caused by the treatment itself. So they concluded, unsurprisingly, that most physicians view the death attributable to the disease as a far more acceptable outcome than death attributable to iatrogenesis. Iatrogenesis means what a doctor does, the action of a physician. Now, I was a prescribing physician. I'm not at all surprised by that asymmetry. And by the way, before that, I spoke about an asymmetry factor of 1 to 2 with a coin toss. Remember that? Here, the asymmetry factor is 4 or 5 to 1, so even more extreme. As I said, I'm not surprised. When I was a physician and a patient died as a result of their disease, well, it's sad, but it's bad luck. If that patient died as a result of my action, it's a very different thing. So, unsurprising. But now I'm asking the patients in this room, do you agree with that? Assume the time of death is the same, and assume the suffering before death is also the same. Would you also be so asymmetric, or would you be more symmetric? And as I ask that question, I'm reminded of what I heard today during your discussions about the prolonged QT, sudden cardiac death. And a lot of you said, well, it's a quick way out. And someone said it's a fast track even. I was very surprised to hear that. So ask yourself, or let's ask ourselves, are we acting in the best interests of patients if we have that asymmetry, that risk aversion? I don't know. Is it possible that if we involved patients more often in the regulatory decisions, and that brings me back to my original question, would the outcome change? Now, colleagues and I have published those curves. You may not be able to read what's underneath. Basically, on the horizontal axis, from left to right, you have an attitude towards risk. On the left-hand side, you would have maximum risk tolerance. So assume the EMA, we wave everything through. Everything goes on the market. Maximum risk tolerance. And on the right-hand side, you have maximum risk aversion. So basically, we say no to everything. And in between that is this continuum of risk tolerance. Now, where you should be depends on what your mindset is. If as a regulator you want to cover your back, what we don't want is newspaper articles or journalists standing outside the building and say, why did you allow this drug on the market? Didn't you foresee that bad outcome? Well then, if we want to maximize or minimize that chance, we should be on the far right-hand side. We should basically say, no, we need more information. No, we cannot tolerate that. But we would be doing a disservice to patients, of course, because no new treatments would go out in an extreme case. So there is a sweet spot somewhere in the middle between risk tolerance and risk aversion, where you maximize the health benefit. You try not to let out everything, because then you would commit an error. You are letting out too many drugs, but you're also not so risk averse that you don't allow any new treatment options on the market. Somewhere in the middle must be that common ground, that best optimal ground. Do we know where we stand on that continuum? No, I have no idea. Maybe we stand here, and maybe, I can only speculate, if we had more patient involvement and we would hear more often from patients, look, if there is a small risk of sudden cardiac death, fine, I'm willing to accept that. Maybe our position would move more towards that sweet spot. It could be. I see someone nod. Possibly you're right. Nobody has the answer. I'm just putting this up because this is something that will keep us busy in the future. So, if we came to use those structured benefit risk frameworks, those methods that you have heard today, I would think it will likely add clarity and transparency, and it might, for us, and now I'm speaking very egocentrically for the regulatory community, it might improve what I call the light-to-heat ratio in the public debate. What do I mean by that? Every argument can be heat or light. If we are criticized by the outside press or by our stakeholders saying regulators are stupid and corrupt, that is heat, that's not constructive. If someone says, okay, regulator, I disagree with your value judgment on this point, then that could be light. That could be a constructive discussion. And I think this is what we should aim for in future, to increase that light-to-heat ratio. Now, to get there may perhaps require two things. We may have to involve more patients and healthcare professionals in the decisions in ways that we yet have to figure out. And it may also require some thought about how we frame the questions. We're all used to benefit-risk trade-offs, and you've heard it today. We talk about benefits and risks. Is that true? And if you go back to that book by Kahneman, he says, when it's gain-loss, you're risk-averse. When it is a risk-risk trade-off, your behavior suddenly changes. So I could put it to you and say, if you're a patient with multiple sclerosis, the benefit is that we may delay the time you are in a wheelchair, and the risk is a small probability of essentially your brain turning into a sponge. That is called PML, that is a side effect. That is a benefit-risk trade-off. But I could also frame it to you as a risk-risk trade-off. I could say, if you don't take the drug, your risk is X, that in 2 years' time you will be in a wheelchair. If, on the other hand, you take the drug, then your risk is that you will develop that side effect. Would that change our behavior? Probably would. So if we did that, it may expose some benefit-risk asymmetry and perhaps influence the decision, for the better, for the worse, I do not know. So let me come to the last of that nervous system loop, outgoing. So you have heard earlier from Laurent how we are struggling to communicate to the outside world what the decision is, how you should use that drug, what is the good, what is the bad. But communication is not an end in itself. It's also about human behavior. And I will illustrate what I mean by way of an example. And please, I'm not pointing fingers at anybody. I know that what I say may be unpopular with some of you, but it has to be said, so please don't shoot the messenger. Here is the example. Several years ago, 2006 it says, in Europe, we approved a drug called Acomplia for obesity and overweight patients. And back then, in the public assessment report, the text was, the effect is moderate, but it may be of clinical relevance for a fraction of the patients. So overall, positive. There was no secret back then what the side effects would be, the unwanted effects. We knew that was perfectly well understood. 3 years later, that drug was withdrawn from the market. This is not very well legible, because in light of post-approval data, and that brings me to what someone said earlier this morning, there is efficacy in clinical trials, and then there is real-life effectiveness. And those two are different. Yes, they are. But now let's look at why. This is the very polite text from our website that you read here. It says, new data, and this was not clinical trial data, that was real-life data, indicated a shorter duration of treatment and reduced beneficial effect. Now, this is code for what? Patients are human beings, and human beings tend to make mistakes and do not always behave in a predictable way. So what happened here was patients simply did not take their drugs. And guess what happens if you don't take your drugs? You will not get the benefit. So patients took it for a week, a month, then dropped off. So the weight loss effect was either zero or minimal. It was much less than in the clinical trials. And something else happened, and that is the last line here. The risk of experience, the adverse mental effects are higher in patients with comorbidity. That did not come as a surprise. We knew that. It was in the label. There were contraindications that said, if your patient has this or that pre-existing mental condition, don't prescribe. And guess what happened? It was prescribed. There was a study from Sweden where they retrospectively looked at insurance claims, and they found that up to 1/3 of patients who was prescribed had exactly the condition that was in the contraindications and in the warnings. So, none of us is perfect. Can we, with our communications as regulators, do anything to modify behavior? This is about utilization, adherence, appropriate or inappropriate prescribing. It is about efficacy versus effectiveness. And the question that will keep us busy over the next years is, can or should we contribute to appropriate adherence utilization? Is there a way to better communicate? You've heard about that. But I don't think personally communications will be the holy grail. We try to communicate, but still, we're all human beings. Should we give better support to technology? You see two pictures on this. There are people who say that all the elements of the technology to improve adherence by patients are out there. There are apps to remind you to take your drug every, 3 times a day, whatever the case may be. There is feedback loops. There is a technology out there that you could put on a pill to inform an intelligent system, has this pill been taken, yes or no? We're not using this. Should we do more? Could we do more? And on the other hand, for better prescribing, as I said, I was a prescriber. Did I ever read those elegant pieces of information that Laurent just described? I confess the answer is most of the time, of course, not. And even if I read it, did I memorize all these warnings and contraindications? Of course not. There is information overload. You cannot expect this from any physician or healthcare professional. So could we do better to provide information at point of care? So these are some of the questions that we need to answer. Let me come to the conclusion. I come back to this nervous system model. So on the incoming side, our challenge will be, how can we fully integrate all these informations that will come in, different types, and how can we distill this into a single decision? On the decision making, how can we reach out, particularly to patients, to understand their tolerance for risks and uncertainty? Because after all, it is not the regulators who take the drugs, not normally at least. It is patients who take that. So their values, your values, should go into that. And lastly, how can we engage both with patients and healthcare providers to seek ways to further optimize the utilization of drugs once they are in the marketplace, to narrow that gap between efficacy and effectiveness? So I've tried to give you a brief overview of what I personally think will be our future frontiers, and I think we will need all your input to help address those challenges. Thank you very much.